I think we had a wonderful discussion. Thank you, all the three speakers. We need to move to the next important session, which is all women in cardiology session. This is a session that we dedicate to women in cardiology. And for that, we have all women faculty. And I would request the speakers and the next slides to be presented, please.
Men folk have to stop their videos.
Slides, please. So we have a wonderful next session coming in here. We have all women in a women patient, all women speakers except Dr. Andrew Choi, who's going to talk about a specialty, and bigger, even bigger, my better half is going to be moderating this session. So
go ahead.
Can we have the slides, please? Yeah. So for this session, I would like to invite moderators, Dr. Neha Sharma, Dr. Archana Jadeja, and Dr. Bhumi Patel, and Dr. Aisha Kadar, Dr. Pooja Vyas, and Dr. Nikhila Panchani as chairperson to introduce our speakers. Over to Aisha. Dr. Aisha.
Thank you very much, Dr. Kamal Sharma. It's always a pleasure to be at CardioCon and also at this very special session. It is my pleasure to introduce our first speaker. As you know, this is a debate, and the debate will be on a 52-year-old woman who was hypertensive and dyslipidemic, presenting with atypical angina with non-specific STT changes in inferior leads, and an ejection fraction of 58% with no evident regional wall motion abnormalities. She also has bilateral osteoarthritis of the knee, and the debate is on which is the best strategy for coronary artery disease evaluation, other than invasive coronary angiography. So that's off the table. It's an imaging debate. And it is my pleasure to introduce our first speaker, who is Dr. Sonali Inamdar. She is a consultant interventional cardiologist at the Inamdar Heart Clinic at Pune in India, and also an associate consultant of cardiology at the H.N. Reliance Foundation Hospital and Research Center. She has numerous prizes and publications to her credit, and she will be speaking first, but I would also like to very briefly introduce our next other three speakers. We have a stellar panel of international speakers. We also have Dr. Purvi Parwani, who is also a very good friend. She is of Indian origin, I believe from Ahmedabad, but she is now doing very well in the United States. She is an assistant professor of medicine at the Loma Linda University in California, and also the director of Women's Cardiovascular Clinic at that institute. So something to watch out for in terms of debate, because this is her home turf, I suppose. And she also has numerous publications to her credit. We also, to debate on the role of CT angiography, we have Dr. Andrew Choi, who is the co-director of Cardiac CT and MRI and associate professor of medicine and radiology at the George Washington University of Medicine. He is a national and international thought leader in cardiovascular imaging and is an author of over 100 abstracts, so very prolifically published in the arena as well. And last but not least is Dr. Renee Bullock-Palmer. She is a cardiologist as well as a board-certified cardiovascular and nuclear as well as imaging specialist. And she comes from Jamaica, but she is also now, I have the pleasure of knowing her off this as well as one of the winners of the Women as One Escalator Awards. And she's also known to be a phenomenal mentor. So a stellar panel today, and we're really looking forward to the debates. I will hand it over to Dr. Sonali Inamdar to kick off the debate today.
Dr. Neha Sharma happens to be Dr. Kamal Sharma's wife. That is a special introduction I wanted to give. Thank you. Please go ahead.
Thank you, Jayesh Bhai, for introducing. Hi, everybody. So just a second, I'll just want to say that I've been in last year also, I was on session with Dr. Aisha and Dr. Purvi Parwani last year. And Dr. Purvi is like a family member to me. So hello, everybody. Please continue the session. I'm there.
So I'd like to extend my warm gratitude to Dr. Kamal Sharma and to Dr. Neha Sharma, ma'am. It's second innings for me in this conference. We had met last year, and it's so wonderful to meet all my colleagues and friends again this year around. So I'll be speaking on the approach to this patient in terms of ischemia evaluation of stable coronary artery disease, and I'll be talking on pharmacological stress echo. Again, I just want to introduce a little concept known as the paradox of choice, because now we've been inundated with so many choices in our lives and in our day-to-day world. Just as a start, this is a menu card of a restaurant in a ordinary restaurant in Pune, and you can see the immense number of choices that you've got to face. And the problem with having so many choices is that when you have so many items to choose from, you are confused. There's a lot of stress. And this is known as the paradox of choice, in which the more number of choices you have, your happiness quotient goes down. So less is in fact more, and too much choice adds to a lot of conflict. What we suffer from in today's world as physicians, as cardiologists, is something known as the opportunity cost, which means that the attractive features of the choices that you're not making add up to make the choice that you actually do seem less appealing. So similarly, when it comes to the immense number of choices that we have in terms of CAD evaluation of a stable coronary patient, we have anatomical tests like a coronary CTA. We have a host of stress tests like the exercise ECG, stress echo, stress MRI, and stress nuclear scans. I've not mentioned the prices here, unlike a restaurant menu, because the cost, of course, differs from region to region, country to country. So that's up for debate. So let's see, how do we deal with this paradox of choice in such people who come with evaluation for coronary artery disease and who have stable angina. So as Dr. Ayesha has mentioned, that we are talking about a 52-year-old female who has some non-specific changes in her ECG, who's unable to exercise, and who has certain risk factors like hypertension and dyslipidemia. Now, what would be the best strategy? Now, if we go by the old guidelines, we typically risk stratify these patients by going talking about the pre-test probability of such patients. So considering that she has had atypical angina and she's in her mid-50s, her risk before undergoing any further test is at a 6% pre-test probability. However, in 2021, that is last year, new guidelines have come up which have lowered the pre-test probability of these patients even further. If you notice the numbers here as compared to the numbers in the prior guidelines, we see that most of the patients, irrespective of gender and considering both chest pain or dyspnea as a feature, as a presenting feature, most of their pre-test probability numbers is quite low. That is because the overall incidence of an obstructive coronary artery disease in the general community in patients who have stable coronary artery disease is less than 10%. So if we look at our patient, she falls under this particular category in which her risk is in fact less than 15%, and she would in fact fall in the low risk category. However, we cannot just treat patients as numbers. We cannot just go by the pre-test probability in its entirety. We have to consider certain other considerations. We can add a calcium score and improve the pre-test probability, or add on to the pre-test probability and get a further understanding of her risk status. Additionally, in these new guidelines, atypical angina is no longer a term. What we have now is either it's a cardiac angina, which is very typical with the central pressure, squeezing, gripping chest pain, or it could be possibly cardiac, which lies in the center, or it could be a non-cardiac chest pain. So going by her symptoms, we could probably say that she falls in the possibly cardiac category. And let's just assume that she falls into this intermediate to high risk group. Now, how do we approach these patients? If you notice this very wonderfully colored pyramid, which has been proposed by the latest guidelines, it shows that in stable chest pain evaluation, the intermediate risk and the high risk patients are clubbed together, and then we approach them in a similar manner. So the approach to these patients is either by going down the anatomical pathway, that is by doing a coronary CT, or going down the stress testing pathway. Now, there have been certain factors which favor the use of coronary CT versus stress testing. For example, if we have younger patients and who are not on optimal preventive therapy, we can go for a CT coronary angio. But the use of CT is more for ruling out an obstructive CAD, that is more than 50% coronary artery disease. However, if you look at a patient clinically and decide that she's likely to have a higher likelihood of ischemia, you look at which region she comes from. If this is an Indian patient, we know that South Asian patients have higher propensity towards multivessel disease, and you want to rule out ischemia in such a patient, then you go down this ischemic pathway and consider a stress testing pathway. The ESC guidelines also tell something similar, where they say that the choice of the test is based on clinical likelihood, the patient characteristics and preferences, and of course, the availability and local expertise. So you either go down the coronary way, coronary CT way, or you go down the stress testing pathway. So as we all know about the ischemia cascade, when there is a coronary blockage, just before the chest pain occurs, a lot of abnormalities take place in the myocardium. It begins with perfusion and metabolic alterations, which are detected by nuclear imaging, whereas other changes like diastolic dysfunction, regional wall motion abnormalities, and ECG changes happen much later. And these are the ones which are picked up by pharmacological stress echocardiography and also by MRI. As we go down, the tests become more specific. So what are the various methods that are used for stress echocardiography? More commonly, of course, we use an inotropic agent, which is Dobutamine, with the help of atropine. It has beta-1, beta-2, and alpha-1 agonist action. And at a lower dose, it has a balanced effect on the peripheral vasculature. And at a higher dose, there is a greater beta-2 response, which leads to peripheral vasodilatation and hypotension. On the other hand, there are some vasodilators like dipyridamole and adenosine, which cause mild distribution of blood flow. This is a less sensitive test for regional wall motion abnormality, and it is better for relative perfusion changes detection. Now, when it comes to a pharmacological stress echo, more specifically a dobutamine stress echo, we can have a big scope of various diagnostics which we can pick up in a particular patient. In addition to the basic parameters like the ECG and the heart rate and blood pressure, we are able to see the regional wall motion abnormality and wall thickening. We can see ejection fraction changes. We can get very nice pictures of transient LV dilatation, which points towards multivessel disease. So measuring the end systolic volume on an echo in a dynamic way, you can see the LV cavity dilating in front of you is something which is very useful, and it gives you a prognostic indication and tells you that there is something wrong. We can calculate the ischemic threshold of that patient. An ischemic threshold is the heart rate at which the first ischemic changes are detected on stress echocardiography divided by the maximum heart rate as per the age of that patient. If it is less than 60%, we can prognosticate the patient and tell that the patient has a higher risk. We can use strain and speckle tracking and also use contrast echocardiography to see the segments in a better way and to delineate perfusion abnormalities. As I mentioned, risk stratification and prognostication is very useful when it comes to the use of dobutamine stress echo. When you have regional wall motion abnormality, the event rates rise up to more than 6%. When there's a transient ischemic dilatation, the rates rise up to 19% annually. We use dobutamine stress echo when you want to assess a preoperative risk. As I mentioned, the ischemic threshold also helps in telling you the prognosis, and contrast use helps to improve the prognostic value. Now, this is a very interesting graph which shows that even if you get a false positive dobutamine stress echo, it does not mean that you just stop there, because it has been shown in this study that even with a false positive dobutamine stress echo, which was shown on coronary angiogram to have a non-obstructive CAD or a normal coronary artery, the survival still decreased over follow-up, which means that this points to the presence of something microscopic. There could be microvascular dysfunction, or the patient could have a subclinical cardiomyopathy, which was unmasked by the dobutamine stress echo test. This particular pattern is not seen with a false positive exercise stress echo. When an exercise stress echo is positive and it is proven to be normal on a coronary angiogram, the survival is similar. It does not dip. Other very important uses of using a dobutamine stress echo is we can find out other causes of chest pain or dyspnea in a patient, like HCM, Takotsubo cardiomyopathy, pericarditis, embolism, valvular diseases. One important issue is when patients have dyspnea, you can do a lung scan immediately, dynamically, and you can find that there are B lines, there are comets, which point to the presence of fluid in the lungs, which have happened there and then because of the exercise that was induced. Also, dobutamine stress echo is useful to detect viability if there is a baseline regional wall motion abnormality. This is an example of a dobutamine stress echo in which various heart rates have been denoted here. This is a 4-chamber view in which the LV is on this left side. Here you can see at higher heart rates, there is a dilatation of the LV cavity. The end systolic volume has increased. And here you can see that the lateral wall has become akinetic. In this particular group of cine images, this is a 2-chamber view in which initially the LV cavity is nice and triangular. It becomes dilated at higher heart rates, and the inferior basal and mid wall has become akinetic. So how do you talk about the performance of various non-invasive stress tests to detect an anatomically significant coronary artery disease? Everything is about sensitivity and specificity. When you talk about a coronary CT, it has a very high sensitivity, but its specificity is quite low. Similarly, when you talk about nuclear imaging tests, they have very high sensitivity, but again, their specificity varies. Dobutamine stress echo also has a good amount of sensitivity, and it maintains a good amount of specificity as well. When you look at something known as the likelihood ratio of a test, that is, when a particular test is positive, does it really mean that the patient does have that disease? You can see that with the dobutamine stress echo, its likelihood ratio is quite high. So it has a very powerful index to rule in a particular disease.
My apologies, Dr. Inamda. I think your time is up.
Yeah,
if you
this is my last slide. Yeah, this is my last slide. So let's keep it simple. Let us avoid decision fatigue. Let us avoid paradox of choice. Let us just choose a test which will help us assess a patient in terms of morphology, physiology, as well as prognosis. The latest guidelines have mentioned that when it comes to stress tests, the test choice should be guided by local availability and expertise. They have not put one test above the other. And when it comes to a dobutamine stress echo, you have to consider the patient characteristics, the accessibility and simplicity of the test, the local expertise, the costs, and also to be a bit flexible and to not hesitate in adding or sequentially adding other tests in case you feel you want more information. Thank you.
Dr. Shonali, for a very informative talk. Now we'll be moving to our next talk, and from the red corner we have Dr. Purvi Parwani, and I'll again take this opportunity to introduce Dr. Purvi Parwani, who is my MBBS senior, and we are both from the same city and from the same college, and her contribution in the field of cardiology has made us all proud. She is an amazing teacher and a wonderful person, and she would be debating on stress CMR would be the best strategy in this case. Dr. Purvi.
Thank you, Pooja, for that lovely introduction. It's always homecoming for me, and really happy to see all of you here. So I'll be speaking about stress CMR today. My disclosure is that I'm a multimodality imager. So quite frankly, in any of these categories, if you put me, I can debate and I can tell you why that modality is good because, I know my toolbox. I have many tools in my toolbox, and according to the patient I see, I use those tools very effectively. And, but right here, I am here to present my favorite modality, and that is CMR. No doubt. So what I'm going to do is I'm going to let the science speak for each modality and tell you why stress CMR is a good strategy. So we have this 53-year-old woman. She has hypertension, hyperlipidemia, severe arthritis. We haven't been told why she has severe arthritis, maybe some rheumatic condition. We don't know. She has atypical angina. And as Dr. Imamdar very nicely pointed out, that's not the term we use anymore with new guidelines, but nonetheless, she has chest pain that has been thought to be anginal, maybe not, maybe. And she does have some non-specific ST changes. She hasn't had any previous cardiovascular evaluation. So the question here is best stress modality, and rather than the cardiac cath, which I see happens more often in India than not. So I think the best thing is why this patient has, the questions I want to answer is, what's the cause of this chest pain? Is it truly cardiac or not cardiac? Why does this patient has ST changes? How can I get this information, all these questions answered, if possible, in one modality? Because as we know, cost is a big issue back home. And what does this patient need next? Do they really need the test, or do they not? And what am I going to tell this patient about their overall prognosis? Particularly given the risk factors they have. Maybe they have rheumatoid arthritis, maybe they are menopausal, and they do have this non-specific ST changes. So when it comes to the best stress modality, I want to go for a test that's accurate, safe, appropriate, has management and prognostic implication, and also is cost effective. So, for the consideration of this debate, these are the points that I'm going to touch upon. Whether getting an anatomy in a patient like this, is it going to help us with her ST changes or her chest pain? Are we going to be able to tell her what exactly is causing her chest pain? Are we going to be able to tell her that she affords all the radiation that a CT or a nuclear stress test brings? Or if her dobutamine stress echo is negative, she should go home and rest and forget about having cardiac chest pain. So that's what I'm going to debunk here. And I'm also going to tell you the sensitivity and specificity of each test. So as Dr. Imamdar very nicely pointed out, yes, this patient, if you take the criteria by pretest probability, she kind of falls into the low risk category, but then she also forgot why she has the increased likelihood of having CAD. She already has the risk factors for CAD. She has hypertension, she has hyperlipidemia. We have already been told she has some sort of arthritis. Rheumatic conditions, as we know, are responsible for premature coronary artery disease. And maybe she's menopausal. That information wasn't given to us. She's 52. She's in that age group. So again, for women, this pretest likelihood, in my opinion, doesn't matter, because I'm going to take that individualist approach. And for this particular patient, I think she has increased likelihood of having coronary disease. Now, I'm not using the word macrovascular disease or microvascular disease, because that's what we are going to figure out. As we know, 30% of the women that present with chest pain, they have microvascular disease, and none of the modalities that my opponents are going to pose do give any information on microvascular disease, except PET, which unfortunately is not available in India. So also, as we have already pointed out, that this patient has resting EKG changes, and these resting EKG changes again put her in a different category. So although we thought that this patient may be in low to intermediate risk, in my opinion, this patient has clinical likelihood of CAD. All the present models kind of underestimate the women having CAD, particularly the microvascular CAD. So these all things need to be considered very carefully. And as Dr. Imamdar very nicely pointed out, the guidelines suggest that in this case, you can go for anatomical testing or you can go for stress testing. And I will tell you why stress testing is a better approach, but compared to anatomical testing, and within the stress testing, why Stress Cmr is the best approach. So of course, we have already looked at the sensitivity and specificity, all the modalities kind of, particularly if we talk about dobutamine stress echo, unfortunately, the problem with the dobutamine stress echo is when it is negative, it does not tell me much. It doesn't tell me much about the microvascular disease. When it comes to stress MPI, we all know that if there is no attenuation correction, half of stress MPI that we read are wrong. And of course, I'm going to talk about why coronary CTA is not a good modality. So let's talk talk about the accuracy. So this is CE mark trial where they took patients with intermediate probability CAD, and they compared them head-to-head SPECT, and CMR was able to perform better than SPECT. In this study, this was the first study. This is the real-world patient that we see. So we already have established in the literature that Stress CMR is better strategy than SPECT. When we look at Stress CMR, because of this black blood sequence that we use, not only we are able to tell you about the ischemia, but also we can tell you about the anatomy. So it's not just a ischemia test, but if you use one more sequence, you are also able to see coronary arteries very well. Now, when we look at the safety, look at the radiation on the right side. When I Googled nuclear stress tests in India, all that came up was thallium. Thallium is a criminal activity, in my opinion. No one should be using thallium in 2022. Look at the radiation that thallium, and technetium, these isotopes use. If it was my family member or my patient, I would never want them to get that kind of radiation. And also, same applies to cardiac CT. Yes, retrospective, cardiac CT perhaps here has way more radiation than the CTs that we utilize these days. And newer CTs definitely have less radiation, but it's still radiation. And one can argue that if you want to go for an anatomical test, perhaps cardiac cath is not a bad idea because it's probably, if you use the contrast and the radiation wisely, you can give the lot of information in the same amount of radiation. So to my mind, particularly in Indian subcontinent, anatomical testing, when we look at the cost and the radiation, perhaps cath is a better idea. But when it comes to ischemia, again, the cath won't tell you why this patient has chest pain. It would just tell you that there is no atherosclerosis and there is no obstructive CAD. So in my opinion, safety-wise, other modalities, except Dobutamine echo here, kind of take a hit. When we look at the management and prognosis, this was an NEJM article. And this article, Nagel's group from Germany, they compared in a multi-center trial role of Stress CMR compared to FFR. And again, compared to the FFR strategy in patients with risk factors, this strategy, were similar. Also compared to FFR strategy, Stress CMR performed very well when it came to downstream testing. We all know with CT scan, with a coronary CT, downstream testing is, way more likely, particularly in real world experience, because we all get scared of atherosclerosis. We all get scared when there is an intermediate atherosclerotic lesion, and we want to give that patient benefit of the doubt and make sure there is no obstructive CAD. So in this paper, particularly Stress CMR showed not only it was cost effective because it led to less downstream cath, which a lot of Indian cardiologists perhaps won't like, but it's a cost effective strategy even when it comes to FFR. And this again was proven in the real world experience. So this is the registry data, again, multi-centers across the United States, and it showed that not only CMR reduced the need for coronary revascularization, but also this less revascularization was associated with better outcomes. So it wasn't that, it was a false negative study. It actually, a negative study meant that those patients had excellent prognosis. So I think that I have, rested my case here with the management and prognosis. And then let's come to cost effectiveness. So I wanted to talk to this audience about the cost effectiveness in India. Granted, I looked up the prices on Google yesterday, but a CTCA in India cost around 15,000, and nuclear is 42,000 rupees. Dobutamine stress echo is the cheapest, 5,000, because it has been, there long, and a stress CMR costs probably between 8 to 10,000 rupees, according to the Google estimate. Now, I know that I can be wrong, but when we look at the cost-effective analysis that is already done for CMR, what it showed is the no imaging strategy was associated with low quality life years, but when they applied, and the worst cost was associated with angiogram, but when they applied both the cost as well as the better quality of life, it was the Stress Cmr that that was able to shine in comparison to any other stress modality. So again, it's a one-stop shop. You get one test and you're going to get all your answers, and that's one of the biggest arguments for using CMR. Now, microvascular disease, again, we know for women, particularly for women that we presented here, microvascular disease, 30% of the women have it, and none of the other stress modality, include expect MPI, is able to tell you if a woman comes with microvascular disease. Now, this concept may be new, but we all know that women do present with microvascular disease, and unfortunately, anatomical tests like CT are not able to figure this out. So if we just pay attention to this slide, by using what we call quantitative stress CMR, we are able to tell you if that patient has the myocardial blood flow that is optimal or not. If the myocardial blood flow right here on the right side, if you pay attention, if the global stress myocardial blood flow is optimum more than 2.25, that patient has normal coronaries, both macro as well as micro. You can tell that patient that go home, this pain that you are experiencing is not cardiac, because you have told them both about macro and microvascular disease, versus if you have less myocardial blood flow, then you can figure out what exactly is the cause for that patient's INOCA, also known as ischemia without any obstructive coronary disease. So again, these are just some more, slides. So this is the normal microvascular reactivity. So you can see this is the rest CMR on the right side below. This is the stress CMR. And look at this abnormal microvascular activity. At rest, you have nice perfusion, but at stress, you have this rim of darkness in the endocardium, which is classic, for microvascular ischemia. Similarly here, a globally normal will shine up on the left side, and on the right side, the blood flow is low and it is globally low, and that can be responsible for microvascular disease. Now, why coronary CT is not a good modality, and I will debunk some of the ischemia trial beliefs that people have. Is this test going to tell you, what is the cause of chest pain for this patient? The answer is no. Am I interested in knowing what's the cause of the patient's chest pain, or am I interested in knowing how much amount of atherosclerosis does the patient have? I'm not interested in knowing what kind of atherosclerosis this patient has. I'm more interested in knowing, why does this patient have chest pain? My CT colleagues often use the argument that CT, using the PROMISE trial, that CT and PROMISE and the Hart trial, that CT led to better outcome. But we must keep in mind that CT led to better outcome because every patient got atorvastatin and aspirin. And my argument is, why can't we just tell all our patients with mixed hyperlipidemia to take atorvastatin and aspirin whenever it is appropriate? So why do a test and tell them that you have atherosclerosis? Why not just directly apply that preventive strategy, tell our patients to apply dietary and lifestyle modification? Now, the positive predictive value, because of this reason, for CT is not very robust. Is CT a gatekeeper for Cath? I would argue not. There are a lot of real world ER studies which have shown CT leads to more downstream Cath, which is not the point. And that's what does not make it cost effective, particularly in Indian subcontinent. And the argument all my colleagues make, I love coronary CT, but they like to make the argument of left main disease. Now, let me remind you, in community, the left main disease is only present in 1 to 2% patients. It is not very common. And a stress CMR would be a great strategy because it does not have balanced ischemia, as you can see with stress MPI or any of the nuclear modalities. So if a patient has left main, stress CMR is going to show you So in my opinion, the ionizing radiation also makes a CT a safety point questionable. So for all that reason, a coronary CT for this patient, in my opinion, would not be ideal choice. So I have rested my case here. I've shown you why. Yes, I've shown you why CMR is safe, efficacious, appropriate, has management and prognostic implications, and it would be the best strategy for this patient. So I was going to show you some examples of the stress CMR. This is an example of a completely normal stress CMR. On the bottom, you have the resting images. On the top, you have stress images. As you can see, when the contrast agent comes in, there is nice perfusion of the entire myocardium. This patient also did not have any sort of, we could tell her EF, and she did not have any sort of previous myocardial infarction. So one test that gave us a lot of answers. And then I will show you real quick what an abnormal stress test abnormal CMR looks like. This is a smoker, a male, substernal chest pain. And look at this patient's stress CMR. So pay attention to those arrows. As you can see in the endocardium, there is less perfusion, particularly the apex has less perfusion all over. And I will, in real quick, I will show you the Cath. This patient also did not have any previous infarct, and on Cath he was found to have multivessel disease, including significant LAD, circumflex, as well as RCA disease. Again, this patient had multivessel ischemia, no myocardial scar, viability was present, and surgeons were able to take him. So if you are interested, check out the stress perfusion series on YouTube by SCMR that we were able to put out. There are 6 sessions and would give you a lot of information about stress CMR. So in my opinion, dobutamine stress echo is not a good choice because it does not tell you about microvascular disease. It also has poor sensitivity. Stress MPI is not a good choice because it has a lot of radiation. It does not tell you anything about the EF accurately, and it does not tell you why does this patient has ST changes. Accuracy can be debated for stress MPI. CT coronary is not a good choice because of the radiation. It doesn't tell you the cause of the chest pain. It does not tell you the EF, and it leads to more downstream testing in addition to not giving you any information about the microvasculature in this woman who is at higher risk of microvascular disease. And of course, stress CMR, because of all the reasons I told you, is safe, appropriate, cost-effective, and evidence-based strategies. Thank you very much for inviting me, and I'll be happy to take question at the end.
Thank you so much, Dr. Purvi. And everybody would agree that it was a wonderful talk with a lot of information and insights. Thank you, Purvi.
Okay, now I would like to tell you that Dr. Andrew Choi has a pre-recorded session. So we'll be playing it now, right here.
Dr. Andrew has actually poetically made it an all-women session. As a mark of respect, he said only a pre-recorded session.
Hi, I'm Andrew Choi from George Washington University in Washington, D.C. And I'm honored to participate in CardioCon this year. I want to thank Dr. Sharma, the organizers, Dr. Parwani, and others for the opportunity to participate in this debate. I apologize that I can't join you this year, and I hope to be able to come back next year and hopefully even come to India. And so what we want to do over the next 10 minutes is to discuss in this debate, why is CT angiography not only a safe and reliable option, but the best option for our patient presented. These are my disclosures. And so it's presented as a 52-year-old woman with a couple of risk factors: atypical angina, normal heart ejection fraction, and severe bilateral osteoarthritis. And I think to understand why CT angiography would be the best test, we should think about our general goals of CAD imaging. We want a test that's safe, that's simple, that meets appropriate use criteria, allows for diagnosis of symptoms, enhances prevention, is supported by the highest quality randomized controlled trial evidence, aligns with guidelines, and allows for the best downstream decision making. And so as we know, and this audience knows very well, there's a high CAD prevalence in India, particularly in the north and in the south. And when we look across multiple data sets, CAD is a particular issue in young adults, even aged 20 to 40, that over 50% of coronary disease mortality occurs in individuals under the age of 50, and a quarter of acute MIs are reported in patients under 40 in the South Asian population. And in the United States, we can look to these examples of younger individuals, President Bill Clinton in his 50s who had a heart attack, even after a normal stress test. Rosie O'Donnell, an actress who suffered a heart attack at the young age of 50, and Carl Ruiz, who's a celebrity chef on the Food Network, who died of a heart attack at age 44. Where does CT allow us to do? It's a comprehensive assessment. Multiple studies have shown very high accuracy and high negative predictive value for obstructive CAD of over 95% in both stable and acute chest pain. CT allows for the evaluation of non-obstructive CAD for cardiac function if protocoled appropriately, myocardial assessment, mass, aorta, and LVAD. Multiple studies in the Protection 6 registry and Cad Imaging have shown that it can be done at low radiation dose around the world and at low cost. About $180 is the reimbursement in Medicare in the United States. So it's at low cost. And so I liken a CT to a Tesla. It gives you all of the modern things that you want in a CAD test. Now, when we look at the spectrum of CAD, cardiac CT will allow for identification of both non-obstructive and obstructive CAD across the spectrum of CAD, and that we should point out that a normal stress test does not equate to the absence of CAD, because a stress test will miss the early or non-obstructive CAD. We know this is important because most ACS occurs in non-obstructive plaques. This is from a trial called ICONIC that did case control from the much larger confirmed registry. And on the left, when you look on a per patient basis, 2/3 of the patients in the ICONIC trial presented that had stable CAD with a later MI had initially 50% or less than 50% stenosis. And that when you look at the culprit lesions from those patients, it was 3/4 had non-obstructive or less than 50% stenosis. CT uniquely allows for evaluation of a sex-specific plaque signature in women. And this is from a review article on the left that we had put together. And women have smaller vessels. They have, while lower plaque volume and lower CAC score, and maybe non-obstructive, which CT uniquely allows you to identify non-obstructive CAD, women are still at risk for major adverse events. And it has to do with the plaque type that's present. And from the SECT, we've been able to really identify higher risk plaque features that include non-calcified plaque, low attenuation plaque, that even with non-obstructive CAD have similar prognostic significance to obstructive CAD. Now, when we look at the evidence, there's been tremendous evidence generation in CT over the last 15 years. And this is from an editorial that we put together summarizing this, including a number of major trials, including the Ischemia trial, the PROMISE trial. We have a number of guideline statements and education milestones. And so in 10 minutes, I can't go through all of this, but I do want to go through the Scott-Hart trial. That, as you recall, this was 4,000 patients with suspected angina that were randomized to standard care, including stress testing, exercise stress testing, versus stress testing plus CT angiography. while there was no difference in revascularization, there was an increased use of preventative therapies, particularly in the CT arm, and impressively, there was a 40% reduction in death or myocardial infarction in those patients that underwent CT angiography. And this is attributed to the identification of early plaque, the ability to start preventative therapies, as well as identify those patients that would be best suited for revascularization. And so why is this the case? Again, as we point out, these factors, including increased clinician attention to patients with CAD. When we look at a cost analysis of using a CTA-based approach to guide treatment versus recent drug therapies, based on the treatment effect, the cost would be about $400 per year if you account for the Medicare cost of the CT angiography plus the cost of aspirin and statin generic drugs. If you compare that to a PCSK9 inhibitor, $5,800 US per year, canakinumab for inflammation, $16,000 a year, and aspirin, while very inexpensive, has not been shown to have benefit in primary prevention cohorts. Now, when we look at guidelines, the European Society of Cardiology guidelines in 2019 reminded us to assess symptoms, look at comorbidities, and assess pre-test probability, including the presence of LV dysfunction or other factors like an abnormal TTT or coronary calcium. And using the pre-test probability for the low to intermediate risk patients, CT angiography is preferred, such as the patient shown here, the 51-year-old, at low to intermediate probability and risk. And so it is a class 1 indication in the ESC guidelines for CTA being recommended as the initial test for diagnosing coronary disease in symptomatic patients if the CAD cannot be excluded by clinical assessment alone. And this is also based on your local availability and patient-specific factors. We can now point to the new 2021 ACC-AHA Multi-Society Chest Pain Guideline. And I was an official reviewer, one of the official societal reviewers for this guideline. And my congratulations again to Dr. Galati, who was the chair of this guideline, and others that were a critical role in bringing the evidence to the national guideline, like Dr. Blankstein, Shaw, Bullock Palmer, who's in this session today, and many others. And so one important point from Dr. Galati was what's new in the guideline is that the redefinition of coronary disease, that it goes beyond just not being just obstructive CAD, but also being non-obstructive CAD, so that those with lesser degrees of stenosis would benefit from optimized preventative medical therapy. When we take a look at intermediate risk patients with no known CAD, how do we now choose among the best imaging tests? Importantly, CTA has a class 1 indication for the diagnosis of CAD, which is new compared to the old 2012 US guidelines, as well as stress testing. And so what are the factors that favor CTA versus stress imaging? Well, if your goal is to identify both obstructive and non-obstructive CAD, you have high quality imaging, a favor towards younger patients. Now, the older age is not a cutoff for CTA, but it favors younger patients. If you're looking for other things like aorta or pulmonary artery evaluation, but uniquely, we can look at plaque composition, high-risk plaque features, lesion-specific ischemia through FFRCT, and we can guide decisions for goal-directed medical therapy and prevention for these patients. In an acute chest pain population, CTA has been shown to contribute to reduced time to diagnosis and prompt and safe discharge. When we think of the right diagnostic test, you might think about potential contraindications, and the guideline lays this out, and you can look at each society's guidelines for more specific details on contraindications, and certainly you might want to avoid CTA in somebody that is unstable, that has chronic kidney impairment, or has an allergy to iodinated contrast. And so the ideal patient by the ACC-AHA guideline is a younger age patient to be able to evaluate for plaque as well as obstructive CAD that has intermediate pretest probability, that might have a prior functional study that's inconclusive, that doesn't have contraindications. And if you want to have rapid diagnosis, safe discharge, and you have high quality imaging available to you. And so when we go back to the patient and why CTA is the best test, it's safe, can be done at low dose, is simple to do, is appropriate, allows for diagnosis of symptoms with high accuracy to rule out obstructive CAD, supported by high quality randomized controlled trial evidence. It aligns with both European and US guidelines. It allows for downstream decision making, including allowing for identification of early atherosclerosis that would allow for prevention so that we can attack this problem that exists in South Asia and in India. And so in summary, CTA is now class 1 in 2021 ACC/AHA chest pain guidelines, and it allows for improved outcomes and goal-directed prevention by identifying obstructive and non-obstructive CAD. And the last point I'd make is, if it was your friend or family, what is the test that you would choose? And when I talk to many of my colleagues from South Asia and India, their choice would be a CT angiography. Thank you very much.
So after that wonderful speak from all three of you, it's my pleasure to have Dr. Renee. Dr. Renee, it's a pleasure to have you for the session, and over to you.
Great, thank you. Can everyone see my slides? Great.
Yes.
So I'd just like to, thanks. I'd just like to thank the organizers of this year's CardioCon meeting. This is my first time joining you guys. And I'd like to also especially thank Dr. Sharma for inviting me to speak in this session on why nuclear myocardial perfusion imaging is the best option for the presented case. I'm Dr. Renee Bullock-Palmer. I'm the director of the non-invasive cardiac imaging program, as well as the director of the Women's Heart Center at the Boer Heart and Lung Center in New Jersey. I have no disclosures, but like Purvi, I'm also multimodality imager, so I could debate on either sides of the debate here this morning. So for women, 60% of symptomatic women have no flow limiting stenosis. And despite this, heart disease is the #1 killer for women. There's emerging data that has significantly contributed to our understanding of the full spectrum of ischemic heart disease in women, which includes obstructive epicardial disease, microvascular disease, coronary spasm, and spontaneous coronary artery dissection. The role of microvascular dysfunction, vascular inflammation, coronary reactivity, and endothelial function and hormonal influences, as well as oxidative stress and coronary size, all have impact on the development of ischemic heart disease in women, and is being increasingly recognized. I'd also like to remind the audience that women have a higher prevalence of plaque erosion compared to more plaque rupture in men. And in older women, the frequency of plaque rupture increases with each decade. So with regards to the ischemic cascade, which shows, it shows here that myocardial perfusion imaging is able to detect ischemic heart disease much earlier than the other modalities that were debated here this morning. In addition to this, microvascular disease can be detected with PET CFR, with coronary flow reserve, and in addition with PET, you also have PET CT, where you can also detect subclinical coronary artery disease. And of course, PET does not have the limitations that other modalities have, such as MRI, where patients who may have devices are unable to have an MRI, or with CT, where patients have renal dysfunction or arrhythmias are not able to undergo CT. Additionally, there are a multitude of other reasons why nuclear stress testing may be useful. In addition to arrhythmias, patients may be obese with poor acoustic windows for echocardiography. They may also have allergies to contrast. And I'll remind you that with the newer software and hardware, we are able to do nuclear imaging with a very low radiation dose, and in some cases, even less than 3 millisieverts. And also, as I will outline later on in the talk, that myocardial blood flow reserve is very useful in women and can be detected with PET. So there's incremental prognostic value with SPECT, and this study that was led by Dr. Rami Dukhi in 2015 has shown that with SPECT, in addition to clinical variables, EKG variables, and myocardial perfusion imaging, you're able to adequately assess prognosis in patients in a stepwise fashion. Moreover, with PET imaging, You also have the addition of the left ventricular contractile reserve, which also helps in prognostication of patients, and in this particular case, in our female patient this morning. Now, with regards to coronary microvascular dysfunction, this plays a major role in determining myocardial ischemia in many cardiovascular conditions, including angina, with and without obstructive coronary artery disease, and also in cases of myocardial infarction, non-ischemic cardiomyopathy, such as amyloid, hypertrophic cardiomyopathy, Takotsubo syndrome, and heart failure. And many of these have a greater prevalence in women compared to men. Many molecular, functional, and structural mechanisms are also involved and are related to the underlying disease process. Now, coronary microvascular dysfunction is more prevalent in women, as in our case, a patient presented, in hypertensive patients, also in our patient that was presented, and in patients with dyslipidemia, again, in the case that was presented. Other populations for patients with valvular heart disease, so particularly aortic valvular stenosis, infiltrative cardiomyopathies, all have a greater prevalence of coronary microvascular dysfunction. Now, the role of ischemia may be caused by epicardial and also microvascular structural and functional mechanisms. Epicardial causes determining ischemia includes acute plaque disruption with lumen occlusion and epicardial coronary spasm, myocardial bridging, and progressive obstruction with vessel narrowing of a previously present plaque. Coronary microvascular dysfunction can result from an abnormal vasodilatability of the microvasculature and also compressive external forces affecting the intramural microvessels, and of course, microvascular spasm. Now, coronary microvascular dysfunction is not benign and has a greater implication for women with regards to adverse outcomes. In these diagrams that were published in the Journal of Nuclear Cardiology, led by Dr. Viviane Tocchetti in 2017, the diagram on the left shows the distribution of coronary cardiovascular risk by PET MPI, coronary flow reserve. And a coronary flow reserve that was greater than or equal to 2 is associated with a relatively low rate of annualized cardiac death. Conversely, coronary flow reserve less than 2 are associated with substantially worse prognosis, which may result from vasomotor dysfunction arising from a combination of pathophysiologic CAD phenotypes and also multivessel obstructive CAD as well, diffuse atherosclerosis, and coronary microvascular dysfunction. On the right, there's a log-adjusted hazard for major adverse cardiac events in females versus male patients, and it varies as a function of the PET MPI coronary flow reserve. Now, looking at the gender-specific differences, you can see that the effect of gender on cardiovascular events was modified, shows significant difference in outcomes for women compared to men, where for that particular coronary flow reserve, for example, a coronary flow reserve of 1.4 or 1.2, that women have a far higher prevalence of major adverse cardiac events. So bringing it back to our patient, it's a 52-year-old female. She has hypertension, dyslipidemia, which are cardiac risk factors. She also has severe bilateral obstructive arthritis of the knees, which could be due to a multitude of reasons. And also for this reason, she's not able to do an exercise nuclear stress test. So of course, a pharmacologic option is the only option for this patient. Now, the possible etiologies for this patient's angina could include epicardial macrovascular disease or indeed coronary microvascular dysfunction. So as you know, the chest pain guidelines that were published last year in October 2021 also helps to tease out the reasons why myocardial perfusion imaging is a choice for this patient. And as was mentioned before, this was chaired by Dr. Martha Galati, Dr. Philip Levy, and Dr. Mukherjee, and I was fortunate to be a part of the writing group. So in this document, the clinical decision pathways are very important for patients presenting with chest pain. With regards to the choice of testing for patients with an intermediate risk presenting with stable chest pain, these patients may be referred for functional stress testing or anatomic testing. But I will argue that functional stress testing is the option for this patient. Now, one must also remember that it is important to look at the patient-specific features, whether or not they've had an unestablished CAD or history of CAD. This patient has no history. Whether or not they've had prior test results available, and also test availability and local interpretation expertise at one's own institution. Now, in the guidelines, there are several clinical scenarios that were outlined that favor stress imaging, such as patients with an intermediate pretest probability in whom more obstructive CAD is suspected. And I would argue with this patient, 52 years of age, she's leaning more towards that group. And also, additionally, in clinical situations when ischemic guided strategy is required, especially in cases where there's established CAD, or in cases where you're looking for coronary microvascular dysfunction, as I would argue for this patient. Now, cardiac PET with myocardial blood flow reserve also has the benefit of being able to detect coronary microvascular dysfunction. Now, in this patient who is unable to exercise, the options for her with regards to myocardial perfusion imaging is SPECT or PET. However, because we're looking for coronary microvascular dysfunction, I would argue that PET MPI would be the choice for this patient. And as I had mentioned before, that these patients are able to have this test with a very low radiation dose of less than 3 millisieverts with the newer software available. So with the chest pain guidelines in the evaluation of patients with stable chest pain, it's very important that the pretest probability is assessed. And in this patient who is 52 years of age, female, presenting with chest pain, she's lying more in the intermediate range here, more towards the intermediate range here. Now, atypical is out with regards to the guidelines. In this patient presenting with chest pain, she would either be cardiac, maybe cardiac, or non-cardiac. And in this particular case, I would argue that she is in the maybe cardiac range. And therefore, in our patient, I do believe that she's at an intermediate pretest probability for having obstructive CAD. So what are the options for this patient? So with regards to myocardial perfusion imaging, PET MPI or SPECT MPI has a class 2A recommendation in these patients. And if PET is available at your institution, then PET is a choice for this patient. Now, this is a case in our lab where we had a patient that underwent a nuclear stress test, which was a pharmacologic nuclear stress test. This is a 72-year-old female, and you can see that she has a very large area of anterior septal, anterior defect that was moderate photon reduction, and it was reversible when compared to the supine rest images. However, in our lab, we do stress prone on most of our patients, and you can see that in the stress prone images, this defect completely resolved, indicating that this study was indeed normal. Now, also, this patient also had adjunctive use of coronary calcium assessment, and her coronary artery calcium score was 0. So why is this important? In the chest pain guidelines, they recommended that attenuation correction or two-position imaging is reasonable with a class 2B recommendation to decrease false positive findings. And I would argue that many labs doing SPECT or myocardial perfusion imaging should have a method of attenuation compensation, either with attenuation correction software or two-position imaging to improve your accuracy of your reading. Additionally, the chest pain guidelines recommended in patients who have no known history of CAD, this patient had no history, that these patients would benefit from adjunctive use of coronary calcium scoring and has a class 2A recommendation to further prognosticate the patient. Now, with regards to the chest pain guidelines, they had also included assessment of coronary microvascular dysfunction in the guidelines, and also ways in which we can assess these patients. Now, it's very important that with regards to the myocardial perfusion of the heart, that we not just look at microvascular disease with epicardial disease, but also looking at microvascular circulation, which is a benefit of PET with myocardial blood flow reserve. And this is an example. This is the last case of a 49-year-old female who presented with recurrent chest pain, multitude of tests, including cardiac Cath, which were all normal. And she had was referred for PET CT with calcium scoring. And you can see that the SCOUT images that was used for attenuation correction showed no calcium coronary calcification. Her perfusion was indeed normal. However, with the myocardial blood flow reserve, you can see that in all three territories, the LAD, the circumflex, and the RCA, the myocardial blood flow reserve were all less than 1.5. This is 1.3, 1.25, 1.43, and her global flow reserve was 1.33, indicating that this patient indeed had coronary microvascular dysfunction. And with the guidelines, they recommended that PET MPI with myocardial blood flow reserve has a class 2A recommendation in these patients to assess for the presence of coronary microvascular dysfunction. So I would argue that nuclear imaging with PET CT with myocardial blood flow reserve assesses the entire coronary tree from the subclinical atherosclerosis via the assessment of coronary calcification on the non-contrast CT images to the epicardial macrovascular circulation with MPI, myocardial perfusion imaging, to the microvascular circulation assessing endothelial function with myocardial flow reserve. And indeed, in this patient, I believe that this is the most comprehensive non-invasive assessment for this patient. So in summary, pathophysiology of CAD is different in women compared to men. and the women are more likely to have non-obstructive disease. In addition, the diagnostic test strategy for chest pain should be determined by the question that's being asked of the test, and also whether or not this patient has had established CAD or not. Now, one must also remember the availability of testing at one's own institution and the interpretation expertise, and not to forget that coronary microvascular disease is very prevalent in women and should be further diagnosed with PET MPI if available. And it's also prevalent in not only in women, but in hypertensive patients, patients with hyperlipidemia, cardiomyopathy, and also valvular heart disease, such as aortic valvular stenosis. And as I had indicated, PET-CT with myocardial blood flow reserve assesses the full spectrum of the coronary circulation from macrovascular epicardial disease to microvascular disease. And I rest my case here. Thank you very much.
Thank you so much, Dr. Renee. And thank you so much, all the speakers, for your insightful and informative talk. I think that Dr. Purvi has convinced me that I think that MRI gives a lot of information on structure as well as hemodynamics of the heart altogether. So if we keep the debate apart, I think MRI would be the best choice considering its broad diagnostic capacity. But we cardiologists have our toolbox. And as Dr. Purvi rightly said, that we need to choose our tools wisely as per our patient's need.
Thank you, Pooja. I know you may be a bit biased because you got
I think we need to bring out another aspect to this, and Purvi, being from Indian ethnicity, would understand. Moms are so difficult to convince, so are wives. You know, they would say, I don't have a pain. I don't want myself to be going to get a checkup. I'm doing fine. I don't want the day to be, lost for my son or my husband. And usually they refrain from a checkup. That's a bigger social problem rather than what to choose in our side of the world. And the other problem that has now creeped in is the free access to healthcare when you're hospitalized, but outpatient you need to pay from your pocket. Which means if you're hospitalized, your angiogram is free with the various schemes that have come in, including the social healthcare sector, including in India, where you have Pradhan Mantri Yojana, the Prime Minister's scheme, where everybody who's at below poverty line gets a free healthcare, which is 1/3 of in India. And if you want to get even a EKG done, you have to pay out of your pocket. So that is another aspect that also needs to be looked into. And I believe that's also the case with the reimbursement, probably in West as well, because you need to justify every imaging that you do on outpatient basis. I can have comments from Dr. Purvi and Dr. Renee as well on this aspect. Is the reimbursement an issue for procedures in West as well for whatever you do on outpatient basis, say cardiac MR or say CT or even nuclear imaging?
Yes, I agree with that. Our hospital, we actually serve, population of very high prevalence of Medicaid patients. And I do have that challenge sometimes that there are patients that definitely need the test, but they're not able to have it covered by the insurance if it's done as an outpatient. And sometimes if it's unstable angina, I'll just have to admit the patient and get the studies done. So I do agree with that. Thanks.
I would say, Kamal Bhaiya, the other side of the story that I had seen a lot before I left India is women are not paid attention. Their chest pain, often is considered, the money should not be spent on a woman. The money should be spent on the breadwinner. So that's the harsh reality of the India that I lived in. And I know that still in small villages, things have not changed much. So whatever you say, I think women are still ignored all around the world, but more in our countries than, other part, in my opinion. When it comes to Stress Cmr, I think access is a bigger issue than the reimbursement. I think that reimbursement in general, at least in where I am in Southern California, it's not been an issue with, we do all of the imaging. We do Dobutamine, stress echo, SPECT MPI, PET, as well as Stress Cmr, and it's not been an issue that much. That's all I have.
Our eminent speakers have given very impressive lectures. I have a question to all of the speakers. Do we have any approach to the diagnostic modality as a comparison between the Asian Indian women and the Caucasian women for this heart disease, what can be, is there a difference or is it the same everywhere? Is there any data about it? Any trials, any studies about it?
I don't think so. Sonali, you want to take it?
No, I don't think there are any studies, but I mean, the point, especially with a lot of East Asians and stuff, the coronary vessels are very small, and there's a higher prevalence of coronary microvascular dysfunction. And I would argue that in these women that PET and also MRI, I'll turn it to Purvi, would be valuable.
Yeah, no, unfortunately, no head-to-head trial. Hopefully, one of the Indian centers can look up. I think there is something called Dr. Saxena. Can you please mute yourself, sir? Thank you. There is a cohort called Masala study out of UCSF that has studied South Asian population, particularly the Indian population, and they have suggested that coronary calcium is way worse in Indian population. But I don't think I have seen any gender differences. Dr. Walkman is also an expert on women's cardiovascular disease, so if she wants to comment something, feel free, Annabelle.
Yeah, no, as you know, we wrote the scientific statement paper on cardiovascular disease in South Asians in the United States. And unfortunately, the South Asian men and women have worse coronary artery disease than a lot of other races and ethnicities. Women definitely have, earlier heart disease than Caucasian women, but the men have really bad disease. They have early and severe coronary artery disease. And this is something that a lot of South Asian doctors know, but I don't think a lot of other doctors know. And that's why we wrote that scientific statement paper to raise awareness about the heart disease in South Asians. Whenever Americans talk about Asians, they lump all of us together with the East Asians who do have less coronary artery disease than South Asians and Filipinos. And so we wanted to highlight the severe coronary artery disease that we're seeing in young men and young women from South Asia.
Thank you.
Okay, ma'am. Thank you so much. Thank you.
So anything else, any other comments from the chair, or we move to Dr. Annabelle's session itself, which is another interesting session on atrial fibrillation. In India, the AF ablation is something that's not very often done. And that's why what Dr. Annabelle is going to talk about is going to be very important. And that's the debate that we have. So thank you, everyone. Thank you for the previous session. Thank you, Purvi, Dr. Sonali, Dr. Renee, and Dr. Andrew, all the chairs, Dr. Pooja, Dr. Neha, and all the moderators, Dr. Archana and Dr. Bhumi. So we move to next session.